It's May 6, 2023. Welcome to the Room Now podcast. Hi, I'm Jack Cush with Room Now. This week and next week and the week after, we're doing replays from Room Now Live 2023, held in March, but 2 months ago. And we're rolling out a lot of the content, all the individual lectures, the panel discussions. All these are going to be available as videos and audio podcasts of those same sessions. You'll see also going on this week Q&A and questions from the audience that happened during each of the sessions that we had. And then you're going to see, some of the tweets and some of the articles that were written during these sessions. I think you're going to find it really an interesting replay. So the schedule that we have set up this past week, we did a replay of the rheumatoid arthritis revolution in RA therapy that I'm going to talk about on this podcast. Next week, we're going to be talking about the management of psoriatic arthritis. That's going to be on Tuesday, the 9th of May. You can register. The link, there's going to be a link at the end of this podcast that you can register at. The week after, the 16th, we're going to be doing the vasculitis session. The following week is going to be spondyloarthritis, and the last week is going to be another session on rheumatoid arthritis. I think you're going to find these really interesting. So I'm going to begin by telling you to look at one of the feature articles from this week. One of the feature videos from this week. It's a QD clinic, but instead of discussing cases, I actually address some 20-something questions from the audience about RA, specifically about early RA, about JAK inhibitor therapy, and also about the pathogenesis of RA. I think you'll find that really quite informative. So one of the 3 sessions that we had was given by Dr. Mike Brenner from Harvard. Michael is really a basic scientist who works in the rheumatology space and for years has done great research about fibroblasts, these stromal cells that are really integral in the development of synovitis and pannus in RA patients. And he reviewed a lot of the therapies that we currently use and, gave good rationale for why they work, inhibition of TNF, IL-1, IL-6, but showed that while they do much to control inflammation through those cytokine-specific mechanisms, they don't really address the problem of what's going on with the fibroblasts. And fibroblasts can be driven by many, many different cytokines and other mediators like LIF and Notch proteins, and cadherin's also important. The idea is that there are going to be new targets for fibroblasts, and when you look at patients who don't respond, that usually what's predominating in the synovium of those patients are these fibroblast related genes. It was really a really excellent lecture. You can find his individual lecture on our website and on our YouTube channel, but it's part of the replay of Tuesday Night Rheumatology that we did this week. Also, in Tuesday Night Rheumatology, we did those lectures were 25, 30-minute lectures that we gave you roughly 15-minute excerpts of and then had Q&A at the end. So one of the talks was from Dr. Kevin Dean from the University of Colorado, where he talked about preclinical RA and what to do. So one of the takeaways from his talk was that there's good news and there's bad news. So looks like the treatment with methotrexate in early CCV positive RA patients didn't work as far as preventing RA, but did work as far as improving individual parameters like the pain score and the HAQ score, and it was sort of a mixed message. But the bad news was he presented the results of the STOP RA trial, a head-to-head trial of patients with that were basically CCP positive, and they either received placebo or hydroxychloroquine, and really showed no benefit, which is a real problem for many of us. We're hoping that safe, effective therapy like hydroxychloroquine may be helpful in that preclinical RA population. It was really quite impressive to see that these didn't work. So the question is, how are we going to treat preclinical RA at this point? Well, he did show good data that the drivers of preclinical RA and the autoimmune state that typifies that are environmental pollutants, smoking, obesity. But so ultimately, if you have an at-risk population, arthralgias, no synovitis, CCP positive, the best thing you can do is lifestyle modification. Stop smoking, send them to whatever you have to do to get them to stop smoking, lose weight, get good control of, dental health, and go on an anti-inflammatory diet, and also, clean up any lung inflammation, because that might be the first site of what goes wrong in those preclinical RA patients. But a heavy pitch by Dr. Dean for lifestyle modification. And then Stan Cohen gave a great session on the multiple new indications for JAK inhibitors beyond RA, and reviewed the safety data on that, and that's worth taking a look at as well. New this week was an announcement from the ACR that ACR 2023, the Convergence meeting, is going to go back to the old format. There's going to be a full normal poster hall. It's going to be the same duration meeting like it's always been, 3.5 days, so there's a fourth day. And I think it's going to be held this year in San Diego, November 10 through 15, and they're starting to take registrations and whatnot. So last year was sort of like a transition year, getting out of COVID, getting away from the hybrid or the virtual only meetings. This is going to be a hybrid meeting as well, but the format is going to bring back those two things: the length of the meeting and the poster hall. I think that will be popular with many. This week, a claims analysis from a Korean insurance database compared RA patients to a population. And specifically, they looked at seropositive rheumatoid factor, CCP positive RA patients, like 39,000 compared to 54,000, 55,000 normal controls. And they showed, with follow-up of these populations over a 4 to 5 year period, they saw Parkinson's develop in 290 RA patients. So when they did the math on this, that there was a hazard ratio of nearly 2, actually it was 1.7 in as far as the risk of an RA patient developing Parkinson's. I find that a little surprising. They back up their data by saying that if you just looked at only seropositive compared to seronegative, the number was even higher, and that the association with RA and Parkinson's was not seen in seronegative RA. What does this mean? I don't really know. I've had tons of RA patients over the years. The number I've had who have Parkinson's is almost not even memorable. So is this like fishing for a p-value here? The idea is that why they did this analysis is they say that inflammatory diseases are thought to increase the risk of Parkinson's. And so what better large inflammatory population than RA? So they proved this from a statistical significance standpoint, especially for seropositives. I don't know that they've really helped us. I'd be interested in hearing what you think. An analysis of hip replacement surgery from a large registry of this. And this looks at, it was a 5-year analysis, patients getting hip replacements for RA, PSA, OA, spondylitis. Looked at those who were on TNF inhibitors perioperatively, and that includes during surgery, versus those who stopped their TNF inhibitors prior to surgery. And they saw no difference in outcomes as far as failure, loosening, infections, etc. Also, revision rates were not any different if you were on a TNF inhibitor, 2.5%, than if you were on a DMARD, 3%. It was lower if you had osteoarthritis. It was osteoarthritis of the hip. It was 0.8%. So this is a data in support of the idea that you don't need to necessarily stop all therapies when someone has surgery. You know, the ACR guidelines basically say you should hold a TNF inhibitor for one dosing interval based on the duration of effect of that TNF inhibitor. But then there's plenty of data that says you don't stop DMARDs, right? That you continue the methotrexate, you continue leflunomide and whatnot. And of course, this drives the orthopedist a little crazy, but this is a guideline from the ACR and I think it's called AHKS, the Orthopedic Hip and Knee Society. And it's based on evidence, based on expert opinion. An analysis of physician payments, is that linked to what physicians do in real life? So here they looked at from available data they have on who gets what money from who. They categorize whether the physician received no marketing money versus less than 100, but more than one, or more than 100. And then they saw if that correlated with the use of hyaluronic acid injections. So this would have been marketing payments from companies making hyaluronic acid products. And then does that influence the actual prescribing? And it did. I think they had like 20,000 physicians. 41% in this analysis had given some hyaluronic injection. The odds of giving an injection increased significantly with payment. So no payments was the referent. And if you received less than 100, your odds went up twofold. If you received more than 100, and that means like bringing lunch to your office or you being an advisor or whatever. But more than 100, it was like 3.3 increased odds. So overall, you were either 13 or 21% more likely to prescribe hyaluronic acid if you had received payments from a pharmaceutical company. Yeah, that is a conflict, isn't it? Lastly, we got a report about the use of cannabis, marijuana, in cancer patients. About half the patients were mostly colon, breast, lung, and this was sort of just an open label analysis. It's not really good science. No cannabis, THC, CBD oil for that matter. None of this research is really well done, but it does back up my impression that THC and cannabis really do make big improvements in pain and sleep. And that's what they looked at in this study. They showed major improvements in overall pain, sleep quality, and cognitive function, which probably reflects sleep quality, but no change in quality of life. Again, we really need to see better research on cannabis going forward, because right now your best advice is coming from some guy named Paco, and he's not Paco the rheumatologist. So I had an article this week also on prophylaxis and its need in patients who have PJP, pneumocystis pneumonia infections. This was a retrospective study from 3 Korean databases. For over a 12-year period, they found 818 rituximab treated patients, half of whom had received prophylaxis with trimethoprim sulfamethoxazole. Overall, they found that there were 11 cases of PJP and a surprising high mortality rate of 64%. What they saw in their analysis was that glucocorticoids and rituximab drive risk of PJP, but it's really the glucocorticoids more so than anything else. especially if the steroid use is greater than 30 milligrams per day of prednisone equivalents during the 4 weeks, during the rituximab and for the 4 weeks after. That really drives risk. Those are the people who really do need PJP prophylaxis. They did show that the rituximab patients also had a higher risk and were going to benefit with a reduction in risk by receiving Bactrim, trimethoprim, sulfamethoxazole. So, but the numbers on the steroids, it was like the incidence of PJP per 100 patient years was 8 if you're on high-dose steroids, and if you weren't on steroids, it was 0.4. So that's a big time, almost 20-fold higher risk if you're on the steroids. Anyway, that's it for this week's podcast. Be sure to check out the Room Now Live 2023 replays. This week, all about rheumatoid arthritis. Next week, all about psoriatic arthritis. Specifically, we'll be covering the lectures of Laura Coates on remission in psoriatic arthritis, Eric Ruderman and his lecture on JAK inhibitor use in psoriatic arthritis, and lastly, pregnancy in psoriatic arthritis from Dr. Christina Chambers from the Otis database in UCSD. Thanks to AbbVie, the sponsor of these 2 weeks, these 2 sessions on RA and PSA, and their support of Room Now Live. Tune in next week. Take care.